I've carried this burden in silence for far too long. More than 22 years of seeing patients day after day, month after month, year after year. I've watched bright, active, joyful people in their 60s, 70s, and 80s walk into my office or the hospital full of life, only to emerge months later diminished, not by disease, but by the very medical system that was supposed to protect them. And every time it happens, a little piece of me breaks because I know I'm part of that system too. I've hesitated to speak this truth openly because I know it will upset colleagues, upset institutions that profit from volume of testing, upset patients who've been taught that more is always better. But silence has become complicity. After thousands of patient encounters, after reviewing countless charts filled with cascades of unnecessary procedures, after attending too many funerals where the final months were consumed by medical interventions rather than family and meaning, I can't keep quiet anymore. My name is Dr. Michael Kent. I'm a primary care physician who spent most of my career taking care of adults over 60. And here is the hard, unpopular reality I've come to accept. For the vast majority of people, once they reach their mid-60s and beyond, the single greatest threat to their health, independence, happiness, and quality of life is not undiagnosed cancer or silent heart disease. It is excessive, low-yield, fear-driven medical testing. I can already picture the pushback in the comments and in doctors' lounges. This is dangerous advice. Early detection saves lives. Are you telling people to avoid prevention? No, I'm not. I still order mammograms, colonoscopies, blood pressure checks, cholesterol panels, diabetes screenings, vaccinations, all of those when the math of benefit versus risk makes sense for that individual human being sitting in front of me. What I'm saying is that the current culture of medicine has swung so far toward catch everything early that we've forgotten to ask the most important follow-up question. And then what? Because finding something early is only helpful if what comes next actually improves that person's life more than it harms it. Too often, it doesn't. Those polished television ads, those full-color brochures in waiting rooms, those email reminders from insurance companies, they show smiling seniors getting scans, getting peace of mind, getting back to golf or gardening. They never show the rest of the story. The 3 a.m. panic attacks wondering if that tiny spot is cancer, the weeks of dread waiting for the next appointment, the painful biopsy that leaves a pneumothorax, the emergency surgery for a complication, the new medication side effects that sap energy, the label of chronic illness that subtly changes how family members treat you, how you treat yourself. They never show that the pursuit of perfect test results can steal more healthy years than any slow-growing condition ever would. That's why today, I want to take you slowly and carefully through 4 specific medical tests that I see triggering devastating cascades over and over again in people over 60. I'm not doing this to create distrust in doctors. I'm doing it to create trust in your own ability to ask better questions and protect what matters most. Before we get to the tests themselves, let me explain the single most important concept that completely rewired how I think about ordering any test after age 60. Researchers call it the cascade effect, sometimes the testing cascade, the diagnostic cascade, or the medical industrial cascade. Whatever you call it, the pattern is heartbreakingly consistent. It almost always starts innocently. You feel good? Maybe better than you've felt in years. You're walking the dog every morning, meeting friends for coffee, helping with the grandkids, maybe even traveling. But somewhere along the way, maybe a direct-to-consumer ad, maybe a well-meaning family member, maybe an automatic reminder in your patient portal, you decide, or are gently nudged, to get checked out. The test is done, and something shows up. A 4-millimeter lung nodule, a complex renal cyst, a PSA that's a little higher than last year, a shadow on a mammogram, an elevated liver enzyme, a brain finding of white matter changes. Almost always, that something is what we call an incidentaloma, a fancy word for we found it by accident and it was never going to cause trouble. These things sit quietly in the body for decades in most people. They're the medical version of liver spots, varicose veins, or gray pubic hair. Visible signs of time passing, not impending doom. But once that finding is typed into the electronic health record, the machinery starts turning. No doctor wants to be the one who missed something. No radiologist wants a lawsuit. No patient wants to wonder what if. So caution wins. You're referred to a specialist. The specialist orders a more sensitive test. That test is still ambiguous, so now we're talking biopsy, PT scan, endoscopy, cardiac catheterization. Each step increases the physical risk: infection, bleeding, perforation, contrast nephropathy, anesthesia delirium. The financial cost, the time cost, and, most cruelly, the emotional cost. Months pass. You're living in a state of suspended animation, waiting for the next result, canceling trips, avoiding exertion just in case, explaining to worried children why you're tired all the time. And then, in the great majority of cases, often 85–95% depending on the starting test, the final conclusion is benign, age-appropriate, no malignancy, no need for treatment. You're told, it was nothing, you can relax now, but you can't. Not really. The anxiety lingers. The procedural scars remain. The new medications stay on your list. Your sense of yourself as healthy has been permanently fractured. That's the cascade. One low-probability finding spirals into high-intensity medical care that leaves you worse off, physically, emotionally, spiritually, than when you started. I've seen this play out hundreds of times. Let me share just a few anonymized stories so you understand why this keeps me awake. Mrs. Rodriguez, 68, retired school teacher, avid gardener, no symptoms. Got a wellness full-body MRI because her son bought it as a gift. Found a 5 mm thyroid nodule, endocrinology, repeat ultrasound, fine needle aspiration, benign follicular nodule. But she now checks her neck obsessively every day and can't sleep without worrying it will turn cancerous. Mr. Patel, 74, still working part-time, plays golf twice a week. Pre-op for routine cataract surgery, age 70, mandatory cardiac stress test, equivocal result, catheterization, clean coronaries. But now he's on a statin he didn't need before, has new leg pain from the access site, and has stopped golfing because my heart might not handle it. Ms. Thompson, 79, sharp as a tack, lives alone independently. Daughter insisted on brain MRI for occasional word-finding difficulty, report full of chronic microvascular ischemic disease and global atrophy. Daughter now treats her like she has dementia. Ms. Thompson's confidence shattered. She stopped driving, stopped volunteering at the library. These aren't rare outliers. They're the norm when we apply broad screening tools to older, asymptomatic adults. Now let's walk through the 4 tests I see doing the most damage. 1. Direct-to-consumer or elective whole-body scans, full-body MRI, full-body CT, executive health packages. These are sold with seductive simplicity. 1 scan, total peace of mind, find cancer, aneurysms, anything, before it finds you. 30 minutes in a machine, beautiful 3D images, a glossy report. Who could say no? In reality, for a healthy 65 to 80-year-old, these scans are among the most reliable ways to manufacture illness. You go in asymptomatic. The report comes back with multiple findings. A 3 per 6 mm lung nodule, seen in 30–50% of older never smokers. 1 or more renal cysts, seen in 40%. Liver lesions, hemangiomas or cysts in 20%. Adrenal incidentalomas, 5%. Thyroid nodules, 50% in some series, prostate enlargement or nodules in men, ovarian cysts in women, degenerative spine changes, etc. The radiologist, practicing defensive medicine, almost always recommends follow-up imaging in 3 to 12 months or consider specialist referral. From that moment, your identity shifts from healthy senior to person with abnormalities. You start Googling. Every article says, nodules can be cancer. You can't breathe without thinking about your lungs. You can't bend without worrying about your kidneys. Follow-up imaging happens. If the lesion is stable, more waiting. If it grows by 1 mm, which can be measurement error, biopsy. Biopsies in older adults carry real risks: collapsed lung, significant bleeding, infection requiring hospitalization. And after all that, the pathology report usually says benign, no atypia, consistent with age-related change. Multiple prospective studies and systematic reviews, including work published in JAMA, Annals of Internal Medicine, and BMJ, have tracked people who underwent elective whole-body imaging. Results: no reduction in all-cause mortality, no reduction in cancer-specific mortality, but large increases in anxiety scores, depression scores, health-related worry, and rates of downstream invasive testing and procedures. What should you do instead? Focus ruthlessly on functional metrics that predict longevity and quality far better than any scan. Can you walk at a brisk pace for 15-30 minutes without stopping? Can you stand up from a low chair without using your hands? Can you balance on one leg for 10+ seconds? Can you climb 2 flights of stairs and speak a full sentence at the top? Do you wake feeling rested? Can you remember recent conversations and manage your own medications, finances? These are free, repeatable, and far more predictive than internal photographs. Then find a clinician who will do the unsexy but powerful work. Deprescribe unnecessary medications, anticholinergics, PPIs, long-term, sedatives, etc. Optimize nutrition, protein intake, fiber, micronutrients. Address sleep, screen for apnea. Treat depression, anxiety if present. Encourage meaningful social connection. Promote consistent movement you enjoy. That's prevention that adds life to years, not years of medical appointments to life. 2. Brain MRI for mild, age-appropriate memory lapses or senior moments. You're 73. You forget why you opened the fridge. You lose your keys more often. You pause mid-sentence searching for a word. Normal. Universal. But your spouse or adult child panics. We need to check for Alzheimer's, and pushes for a brain scan. I understand the terror. Losing your mind is one of the deepest fears we have. But a structural brain MRI in this scenario almost never helps and very frequently hurts. You get the scan. The report returns with terrifying-sounding language: mild to moderate generalized cerebral atrophy, paraventricular and subcortical white matter T2 hyperintensities, chronic lacunar infarcts, evidence of small vessel cerebrovascular disease, hippocampal volume loss consistent with age. To a non-physician, these phrases sound like a death sentence for your brain. In truth, they describe the brain of nearly every person over 75 who has ever had an MRI. Autopsy studies and large cohort imaging studies, Framingham Heart Study, Offspring Cohort, Rotterdam Scan Study, Mayo Clinic Study of Aging, show that 90% of cognitively normal older adults have these exact abnormal findings. They are markers of surviving 7 or 8 decades on planet Earth, not impending dementia. Yet the psychological damage is profound. Patients hear atrophy and think, my brain is shrinking away. Families read the report and start treating the person as fragile, taking away car keys prematurely, hovering, speaking slowly and loudly. The older adult internalizes it. I must be losing it. Confidence collapses, activity withdraws, depression follows. A self-fulfilling prophecy begins. I've had patients in their late 80s who still teach classes, play bridge at master level, write letters to the editor. Yet their MRI reports read like textbooks of neurodegeneration. And I've seen people in their early 70s with rapidly progressive Alzheimer's whose scans look relatively preserved early on. Structure is a poor surrogate for function. Far more useful first steps when memory concerns arise. Office-based cognitive screening tools, MoCA, MiniCog, Memory Impairment Screen. Quick, validated, actually measure performance. Comprehensive history and lab workup for reversible causes, which cause or contribute to 20–40% of cognitive complaints in older adults. Medications, anticholinergics, benzodiazepines, first-generation antihistamines, opioids, muscle relaxants, vitamin deficiencies, B12, folate, thiamine, endocrine, hypothyroidism, hypercalcemia, sleep disorders. Untreated OSA is devastating to cognition. Mood disorders, depression in older adults often presents as memory loss, pseudodementia. Sensory deficits, uncorrected hearing or vision loss mimics cognitive impairment, chronic infection, inflammation. If those are negative and concern persists, then, and only then, consider structural imaging, usually starting with non-contrast CT to rule out mass lesions, subdural, normal pressure hydrocephalus, etc. For the everyday forgetfulness that comes with normal aging, an MRI usually adds fear, not clarity. 3. Routine or protocol-driven cardiac stress testing, treadmill pharmacologic stress, especially pre-op. You're 72, feel excellent, walk 2-4 miles several days a week, garden, dance at weddings, no chest discomfort, no unusual breathlessness. But you need minor elective surgery, knee replacement, hernia repair, prostate procedure, and the hospital's pre-op protocol says age 70 in-chas cardiac stress test required. Your daily life is already a stress test. You're doing sustained submaximal exertion without symptoms. That's reassuring. Yet protocol trumps physiology. You go on the treadmill or get dobutamine adenosine if you can't exercise. In older adults, these tests have dismal specificity. False positive rates of 30-60% are common because of baseline ECG abnormalities from prior hypertension or LVH blunted chronotropic response, heart rate doesn't rise as vigorously, medications, beta blockers, calcium channel blockers, digoxin, deconditioning or musculoskeletal limitations preventing adequate exercise. Result comes back abnormal or equivocal. Cardiology is consulted. Next step, coronary angiography, cardiac catheterization, invasive procedure, arterial puncture, groin or radial, contrast dye, risk to kidneys, radiation, small but non-zero risk of arrhythmia, coronary dissection, stroke, bleeding requiring transfusion or surgery. They thread the catheter, inject dye, and usually find typical 72-year-old coronaries, diffuse non-obstructive atherosclerosis, some 30-60% lesions, no critical stenoses, no evidence of imminent plaque rupture, no stents, no bypass. Medical management. But the damage is done. You now have a new coronary artery disease label in your chart. New prescriptions. Statin dose increased. Maybe aspirin or clopidogrel added. Maybe nitrate, just in case. Activity restriction advice. Don't push yourself. A permanent sense that your heart is bad. Many patients never return to previous exercise levels. Fear becomes the limiting factor, not physiology. Better approach, rely first on symptoms and observed function. True high-risk ischemia usually produces predictable symptoms: exertional chest pressure or heaviness, jaw or arm radiation, marked shortness of breath disproportionate to effort, near syncope with exertion. If absent during normal daily activities, near-term risk is low. If additional risk stratification is desired, strong family history, diabetes plus other risks, prior smoker, etc., order a coronary artery calcium, CAC, score via non-contrast CT. Quick, 5-10 minutes, very low radiation, 1 MSV, no exercise, no IV contrast. Score 0, Mauer, excellent prognosis, very low event rate next 5 to 10 years. Score 100 on mild elevation, intensify lifestyle plus. Consider statin, score 400. High risk, shared decision about prevention therapies. The CAC gives actionable risk information without automatically funneling you into the invasive pathway. 4. Routine surveillance colonoscopies, continuing past age 75-80 in average risk individuals with prior normal exams. I want to emphasize this strongly. I am a firm believer in colorectal cancer screening. It is one of the few true preventive cancer screenings. We remove precancerous adenomas before they ever become cancer. I recommend starting at age 45, earlier with family history or symptoms, and continuing every 5 to 10 years through the early to mid-70s if life expectancy is robust and prior exams were normal. But after roughly age 75-80, especially if you've had multiple normal colonoscopies and no high-risk features, large villus adenomas, high-grade dysplasia, serrated polyps, strong family history, IBD, Lynch syndrome, the risk-benefit equation flips dramatically. Why? Several reasons. Natural history is slow. It typically takes 15 plus years for a small adenoma to become invasive cancer and then cause symptoms or death. If your remaining life expectancy is 4 to 6 weeks, any visible blood in stool, bright red or dark tarry, iron deficiency anemia with no other obvious cause, unexplained weight loss, 5 to 10% body weight, new or changing abdominal pain, any of these around colonoscopy indicated full stop, regardless of age. Diet as active prevention. Increase dietary fiber to 30-40 plus grams per day from whole food sources. Why? Soluble and insoluble fiber feeds beneficial gut bacteria, production of short-chain fatty acids, butyrate, that reduce inflammation and inhibit cancer cell growth. Dilutes potential carcinogens in the colon, speeds transit time, reducing contact between mucosa and toxins. Best sources: oats, barley, beans, lentils, black beans, chickpeas, split peas, berries, apples, pears with skin, broccoli, Brussels sprouts, carrots, chia, flax seeds, whole grain bread, pasta, popcorn, nuts. This is zero risk, whole body beneficial prevention, no sedation, no perforation risk. In the end, these 4 tests, whole body scans that turn normal aging into abnormal findings, brain MRIs that weaponize ordinary forgetfulness into perceived neurodegeneration, protocol-driven cardiac stress tests that manufacture cardiac patients out of healthy seniors, and late-life routine colonoscopies where procedural harm overtakes distant preventive benefit, share the same tragic architecture. They begin with the promise of safety and control, ignite a cascade of escalating intervention, and too often end with diminished lives. After more than 2 decades of witnessing this pattern, here is what I believe with every fiber of my being. Health in your 60s, 70s, and 80s is not measured by flawless lab values, pristine imaging, or 0 abnormal findings. Health is measured by function and joy. Hugging grandchildren without getting winded, walking to the corner store or the park bench you love, reading a book, or doing a crossword without constant distraction from worry, laughing at the dinner table with people you love, feeling independent, capable, and present in your own life. Sometimes the most compassionate, evidence-based, patient-centered thing a doctor can do is say, "I don't think this test will make your life better, and it might make it worse." Let's talk about what really matters to you right now. When any test is suggested, whether by me, another doctor, a specialist, or an algorithm, please ask these 5 questions slowly and out loud. Why do I specifically need this test today, given my health, my function, my goals? What exactly are we hoping to learn, and how likely is a truly actionable finding? If the result is abnormal, what are the realistic next steps, and what are their risks, time commitment, and impact on my daily life? If the result is normal, how will that change our plan? Is there a lower risk, lower cost, or no test way to get roughly the same information or reassurance? You are the final authority on your body, your values, your definition of a life worth living, not the EHR alert, not the hospital protocol, not the insurance incentive, not even the well-intentioned guideline written for populations, not for you as an individual. If anything in this long conversation has made you pause, reflect, or feel less alone in questioning the more testing is better reflex, please share it with someone you care about. A parent, a spouse, a sibling, a friend who's feeling pressured into just one more scan or routine procedure. And if you want more of these honest, no BS conversations about what actually helps people live longer and better, consider subscribing or following along. I promise to keep showing up with what I've seen, what the evidence says, and what patients have taught me over decades. In the comments below, I'd love to hear from you. Have you, or someone close to you, ever felt swept into a cascade of testing that didn't feel right, or that ultimately caused more harm than good? What happened? How did it change your view of medical care? I read every comment. Your experiences matter to me, and they often teach me more than any lecture or journal ever could. Thank you for giving me the time and the trust to say this out loud. Take good care of yourselves and each other, with wisdom, with courage, and with love. I'll see you in the next conversation. Stay well.